Good afternoon. The topic of this afternoon will be concomitant elective ascending aortic surgery and the employment of circulatory arrest and our experience that does not affect morbidity and mortality. I have no disclosures. As we know, deep hypothermic circulatory arrest is often employed when replacing the ascending aorta, and it definitely adds complexity, not to mention the length of cardiopulmonary bypass, and thus may potentially contribute to the increased morbidity and mortality after surgery. We queried our database over a period of about 22 years, and we revealed between that period, and we queried just elective surgery. We're not including in this analysis patients who came in on an acute basis with dissection, 106 patients. Out of those, 15 had an isolated replacement of the ascending aorta. 3 patients had cabbage as well as a replacement of ascending aorta. 72 patients had valve surgery, which you can see a breakdown, double valves in 4, aortic valve and mitral valve replacements in 4 patients, aortic valve replacement and mitral valve in 6, and it should actually be 59 isolated aortic valve replacements, and 6 isolated mitral and tricuspid in 3 patients. And 16 patients had composite cabbage valves and ascending aortas. Deep hypothermic circulatory arrest was employed in 86, in other words, 81% of the patient population, and we normally do not employ selective cerebral perfusion in these cases. The deep hypothermic circulatory arrest, we range in temperatures between 15 and 18 degrees. As far as our results are concerned, the operative mortality was 3% in the patient group of deep hypothermic circulatory arrest. Non-deep hypothermic circulatory arrest were 5%. As you can see, none of the outcomes as far as renal failure, atrial fibrillation, pacemaker, permanent pacemaker implantation, extended length of stay were affected by this. When we conducted a multivariate analysis as far as predictors of mortality, just gender, with unfortunately female being a higher risk for mortality, and patients suffering from diabetes mellitus, the length of deep hypothermic circulatory arrest time, and we did sub-analysis whether 20 minutes, 30 minutes, and in the isolated cases that we had more than 30 minutes did not prove to be a predictor of mortality, as well as the length of cardiopulmonary bypass, which averages in the range of about 150 minutes. In conclusion, as from our experience, we found elective surgery, replacement of the ascending aorta, circulatory arrest does not increase the operative morbidity and mortality. Thank you very much.
I have one question. We move, like most of the world, to lower degree of cooling with antegrade cerebral perfusion because of the numbers in the literature. And usually, in our centers, the numbers are not big enough to make a real conclusion. So what is your policy now, and which technique do you prefer?
It's a very, very good point, Gil. I have to say that since I am the one who does most of the aortic surgery in our center, I was trained at Mount Sinai where the cooler you went, the better. So Dr. Greek taught us the cooler you are, the better you are, and he rarely employed any selective cerebral perfusion. He did not believe in retrograde. He thought it was a bunch of nonsense, and he proved that scientifically. So that's where we started. I would say that as we see prolonged cardiopulmonary bypass does carry an impact on morbidity, we are evolving. So I would say when I have a routine case now, I would definitely say, and we've also slightly changed our technique in terms of the way we conduct and construct our distal anastomosis. We don't normally use a felt strip anymore, and we'll do, I would say a 1-layer anastomosis, which definitely saves time when you're having a good aorta. And I would say most of these patients, remember, we're talking about elective surgery. We're not talking about patients who have a dissected aorta. So that really is definitely a game changer here. And today, I would say, when I'm doing a distal ascending, I'm not doing a hemi-arch, and definitely not doing an arch. I'll go down maybe just to 24 degrees and feel comfortable in doing that, and I can most of the time get away, I would say 10, 15 minutes. As you know, there is a certain learning curve that, you know, the more that you're doing, you're becoming faster and doing that also. So definitely we're involved, and this is just as far as querying our experience. I would say in the dissections, if we're talking about dissection, I still feel more comfortable doing cooling down to, I would say, about 18, and I'm much more liberal nowadays in using antegrade selective perfusion, and most of the time I will do just a unilateral and not doing bilateral. We now, since we have the INVAS cerebral monitor, which will give me sort of an idea as how well I'm perfusing the brain. So that's pretty much our policy today.
Okay, thank you very much. Any other question or remarks?
I just saw you had 10 dissections in that group.
No, we didn't. This does not have. Then there is an error in the abstract because this is purely elective surgery. We don't include any dissections in that. So I apologize for that.